Hi guys, this is Dr. Santhosh Patil and I am a medicine educator, also a practicing physician. I teach medicine for Unacademy, NEET PG, FMGE as well as INI-CET, and I also teach medicine for those aspiring for NEET SS for Prepladder. Okay, now this is my first video on my very private YouTube channel, and in this video we will be discussing Sjogren syndrome. Okay, let me tell you that regardless of what is the platform, whether I'm doing the session on YouTube live for Unacademy or whether it is going to be a special class on Unacademy or a paid class on Unacademy or my YouTube channel, the notes will be made available to you on my Telegram group, which is known as Dr. Patil's Medmania. I will be sharing the link in the description. Okay, and those who want to get connected to us, like Unacademy has loaded up with the internationally recognized faculty members, and if you want to get connected, you may be able to get a handsome discount of 10% by using the code DrSan2020. And be aware that Unacademy is coming out with this NEET PG 2022 Ultimate Revision Package, where the approach mainly will be MCQ centric. So the content will be delivered through live lectures in MCQ centric, and I am also part of the program. Okay, and remember that the NEET PG exam in 2022 is likely to be conducted in the month of March, so we have very limited time, and probably MCQ discussion is the way to go forward, because if you go with theory preparation starting from very bottom to the top level of learning, then probably time may not suffice. I understand many of you are still not fully come out of the hangover of NEET PG 2021, so you can get connected through this, right? And if you use the code, definitely you are going to get a handsome 10% discount. Okay, now let's go to the topic for the day. The topic for the day is Sjogren syndrome. The other rheumatological disorders, the lectures are available already on the YouTube, and I will be sharing the link in the description, and the links are also available on the Telegram group, and some part is also covered on the Unacademy special platform, so the links will be made available to you. The topic for today is Sjogren syndrome. What is it? It is a slowly progressing autoimmune disorder characterized by lymphocytic infiltration of exocrine glands. I repeat, exocrine glands, because there are various other autoimmune disorders. For example, Hashimoto's. Which gland is affected? An endocrine gland. Type 1 diabetes, an autoimmune disorder. Which gland is affected? An endocrine gland, right? So Sjogren syndrome mainly affects exocrine glands. Mainly affects exocrine glands. And the most commonly affected glands are basically the salivary glands and the lacrimal glands, right? So because of that, the common presentation is in the form of xerostomia, or the dryness of mouth and dry eyes. Right? And because it's a disorder where there are lymphocytes are activated, right? There is a lymphocytic activation, and these lymphocytic activation increase the risk of malignant transformation. And thus, these patients are known to develop malignant lymphomas, mainly non-Hodgkin's lymphoma. Okay, mainly non-Hodgkin's lymphoma, and also maltomas. They are also prone to develop maltomas. So there is risk of malignant lymphomas in these patients. Okay. Now coming to its epidemiology, this is a disorder which mainly affects females. Okay, that too characteristically it affects middle-aged female. If you have to talk about the age range, around 40 to 60 years is the age range where majority of these patients are found. But still remember, it is not uncommon to see a child presenting with Sjogren syndrome, because it can occur at any age, but 80% of the patients are found in this age group of 40 to 60 years. And most of your patients are going to be females. Now, autoimmune disorder and female, there is a strong connection, and that holds good here also, right? So the ratio is 9:1. Where else we hear this 9:1 ratio? In the rheumatological disorders, right? SLE is also a disorder where we hear this ratio of female to male as 9:1. Okay. Then whenever we talk about autoimmune disorders, always remember there may be some degree of HLA association, and these points we should always keep in mind, because these are MCQ areas, especially when you talk about INI-CET. So in case of Sjogren syndrome, HLA-DQ-A10501 confirms a high risk of developing Sjogren syndrome. Apart from that, yes, there is also association with DR3 and DRW52. These two HLA variants are also associated with higher risk of developing Sjogren syndrome. And in autoimmune disorders, when you are reading, also look for non-HLA loci which are associated with high risk. HLA is not the only genetic abnormality that we encounter, right? So the non-HLA loci that you should particularly remember about Sjogren syndrome is a gene called as IRF5 and STAT4. Right? Certain single nucleotide polymorphisms in these genes also increase the risk of developing Sjogren syndrome. Okay. And Sjogren syndrome, based on the etiology, can be classified into two types. The primary Sjogren syndrome, which occurs in isolation, right? It is not associated with other autoimmune disorders. Then we call it as primary Sjogren syndrome. And we will call it a secondary Sjogren syndrome if it is associated with other autoimmune disorder. And remember one important MCQ point: the most common autoimmune disorder that is associated with Sjogren syndrome is rheumatoid arthritis. That is the most common. What other autoimmune disorders are affected? The other autoimmune disorders that can be associated with Sjogren syndrome include systemic sclerosis and SLE. Very, very common, in fact. Okay. Apart from that, overlap syndrome, or what you call as mixed connective tissue disorder. Then chronic hepatitis C infection is also associated with risk of Sjogren syndrome, and certain vasculitis. Right? I particularly want you to remember the first three that I have listed: rheumatoid arthritis, systemic sclerosis, and SLE. Overlap syndrome तो आपको याद ही रहेगा because there is mixture of various autoimmune disorders, so ये भी वहाँ पे figure हो जाता है, right? Okay, and this most common being rheumatoid arthritis is a very, very important MCQ point. Okay, now coming to the pathogenesis of this disorder. So there are genetic factors, obviously HLA-DQ-A1, DR3 and DRW52. Yes, these are all genetic factors. We also discussed about the non-HLA leucos like IRF5 SNPs and STAT4 SNPs. Yes, these are the genetic factors. Apart from that, there may be some role of environmental factors. Very often viruses have been implicated, and also there are case reports of tuberculosis being an inciting agent. The very exact pathophysiological mechanism is not fully understood, but what basically we understand is there may be some role of environmental factors, there is some role of genetic factors, and both put together trigger an autoimmune disorder. What happens once the autoimmunity is triggered? There is lymphocytic infiltration of exocrine glands. And I want you to remember one particular point here. When you see these cells, right, basically the cells are going to be CD4 T cells, CD4 plus T cells. Not the CD8 T cells, they are going to be CD4 T cells. And also remember, there is one closely related disorder called Mikulicz syndrome, where you may be seeing lymphocytes which are going to be IgG4 positive, which is not the case in case of Sjogren syndrome, right? So basically, the point to remember is we see lymphocytic infiltration of exocrine glands like parotid, and these cells are CD4 positive. Okay, the second arm of the pathogenetic process is the activation of B cell. I was discussing about it, right? So these activated B cells cause production of autoantibodies, and this B cell activation has some role in malignant transformation, right? Has some role in malignancy. Okay, so there are production of autoantibodies. Very commonly, you see that patients may be having RA factor, and remember, RA factor positivity need not correlate with joint manifestations. What do I mean by that is, patient may be having only Sjogren syndrome, RA factor may be positive, but he may not be having rheumatoid arthritis, possible. Okay, so it need not always mean that you have Sjogren syndrome and RA factor positive, that means you have rheumatoid arthritis plus Sjogren syndrome. No. Okay, so RA factor can be positive. Some patients may have ANA positivity, and there are two particular antibodies that we should remember. Those are anti-Rho and anti-La antibodies. Anti-Rho and anti-La antibodies are relatively more specific, that they are not very, very specific for Sjogren syndrome, because they can also be expressed in the absence of Sjogren syndrome manifestations in SLE and rheumatoid arthritis patients and other autoimmune as well as rheumatoid disorders. But they are relatively, among the antibody profile that we know, including RA factor, ANA and anti-Rho, anti-La, they are relatively specific. They are not very, very specific. So just because you have found anti-Rho or anti-La antibodies, that doesn't mean the diagnosis has to be Sjogren syndrome, right? You can see them in rheumatoid arthritis patients, you can see them in SLE and systemic sclerosis also, right? But they're relatively specific. You have clinical manifestation of Sjogren syndrome, and you see anti-Rho and anti-La antibodies, and certain other clinical characteristics are met. Maybe you can diagnose the case as Sjogren syndrome. Okay. So what this leads to? The lymphocytic infiltration of the gland leads to increase in the gland size, right? So when you see the patients, very often, like 2/3 of the patients, you will see them with enlarged parotid glands. Like I'm showing you in this image, you can notice the enlarged parotid gland. Yes, yeah. That is because there are a lot of lymphocytes now, and they are occupying the space. Lymphocytic infiltration is responsible for the gland increase in size, not because of the hypertrophy of the glands. Okay. And thus there is also exocrine gland dysfunction, and that leads to manifestation, clinical manifestations. So if the lacrimal glands, there is dysfunction, so there is reduced production of tear, and that causes dry eyes or keratoconjunctivitis sicca. Decreased production of saliva leads to xerostomia. Similarly, decreased production of the output of the mucus glands lining the airway can lead to nocturnal cough. Okay, and also the mucus glands in the skin, right, their dysfunction can also cause dry skin. So these are all the clinical manifestations, right? So keratoconjunctivitis sicca and xerostomia are the 2 points that we should never forget. They are classically associated with Sjogren syndrome. Now coming to clinical features, right? I told you keratoconjunctivitis sicca, a very important finding to note. How do these patients present? These patients usually present with gritty sensation under the eyelids because the eyes are dry, right? The blinking is associated with a gritty sensation under the eyelids, right? They may also complain of decreased tearing, and eyes usually become, because of the loss of tear film, they usually become more photosensitive. So photosensitivity is also a complaint that we can express. Now, when these patients present, when they say that I am experiencing dry eyes, burning sensation, redness, I do feel that the tear output is reduced, or I feel gritty sensation under my eyelids, or some kind of pricking sensation, you do think of keratoconjunctivitis sicca. Now, how do we diagnose? How do we quantify the tear output? Right. So, for diagnosis, we have various modes. One of them is known as Schirmer's eye test, which you are very much familiar with. So what I want you to remember from Schirmer's eye test is the numbers. Okay, so what do we do in Schirmer's eye test? Basically, we take a filter paper and put it in the lower lacrimal sac, right? Lower conjunctival sac, and once we place it in the conjunctival sac, lower conjunctival sac, we are waiting for around 10 minutes to see the wetness of the tear film, right? And we are basically reading at 5 minutes. At 5 minutes, what is the length of this filter paper that has become wet? Okay, so normally most patients, when we read at 5 minutes, will have a more than 10 millimeters of that filter paper wetness. Right. If it is less than 10 millimeters, it is abnormal. But again, for the diagnostic purpose, right? So remember, more than 10 millimeter at 5 minutes is normal. But for the purpose of diagnosis, when we are considering Sjogren syndrome, right, most of the diagnostic guidelines use less than 5 millimeter as the cutoff. Right? If it is between 5 to 10 millimeter, probably you need to repeat the test or look for other possible causes, try to address them and then repeat the test. Less than 5 millimeter, kind of confirmatory that there is keratoconjunctivitis sicca. Right? Less than 5 millimeter is the number I want you to remember. That's why I told you, when it comes to Schirmer's eye test, what we have to remember is numbers. We read it at 5 minutes and less than 5 millimeter is abnormal, right? Okay, so that's about Schirmer's eye test. We can also do something known as tear breakup time. What is tear breakup time? It is the time taken for the first dry spot to appear on the cornea after complete blinking. You have to blink the eye, then open and hold. Don't blink again and wait for the time that it takes for the first dry spot to appear on the cornea. How do we get to know? Well, basically we use some fluorescent methods, fluorescent materials, so that we can pick up the loss of this fluorescent material, right? And if it is less than 10 seconds, it is considered as abnormal. So remember, it was about 5 millimeters for the Schirmer's eye test, 5, and it is 10 seconds, less than 10 seconds for the tear breakup time. If it is more than 10 seconds, it is normal. We can also do a tear lysozyme content. So these are the 3 tests that can be done for the diagnosis of keratoconjunctivitis sicca, which is one of the very characteristic manifestation of Sjogren's syndrome. Right? What to remember from this slide? The numbers. Numbers are the most important thing to remember. Okay. Now coming to xerostomia, another manifestation, dry mouth. Right? How do the patients present? Patients present with difficulty in swallowing dry food. They might need to gulp a lot of glasses of water to facilitate passage of the dry food because they are not able to moisten the food, chewed food. And often the salivary gland size may be increased. So I have already shown you an image. So 2/3 of the patients have an increased salivary gland size by the time we diagnose them. And we have already told you that this increase in size is not because of the gland hypertrophy, but because of the infiltration by the lymphocytes. How do we diagnose? We can do cielometry. Okay. There are now ultrasound, MRI and CT-based cielometry tests available. You can do a cielometry for the diagnosis. And you can also do a biopsy of the minor salivary glands. So you can take a biopsy from the lip, labial biopsy, and this is an important MCQ point. What is the preferred site for biopsy in case of Sjogren syndrome with xerostomia? Not parotid. right? No major glands. We are mainly targeting the minor salivary glands. It is usually picked up from the lips, right? So remember that. I will show you an image of the lip biopsy. You can notice it is a lip biopsy, a minor salivary gland biopsy showing lymphocytic infiltration. You can notice the lymphocytic infiltration in these areas, right? So this is one of the minor salivary gland picked up from the lip biopsy, and you can see there is infiltration of lymphocytic cells, right? So what are we expecting? These cells are going to be CD4 positive predominantly, right? These are going to be CD4 positive predominantly, and we are expecting them to be IgG4 negative, because if they are positive, it points towards one of the IgG4 related disorder, which is also known as Mikulicz disease, Now, coming to other clinical features, right? So patients can also have extraglandular manifestations. These extraglandular manifestations are more characteristically associated with primary Sjogren syndrome. Now, I personally don't mean that the extraglandular manifestations are unlikely in cases of secondary, but in case of secondary Sjogren syndrome, probably whatever extraglandular manifestations we see may be attributed to the primary disorder that is causing it. Like for example, if you say rheumatoid arthritis, the most common cause for the secondary Sjogren syndrome. Now, if they have some extraglandular manifestations like pleuritis or pericarditis, we will attribute it to rheumatoid arthritis rather than Sjogren syndrome. So that is my take on this. That may be the real reason why there is stronger association of extraglandular manifestations with primary Sjogren syndrome. Okay. So for exam's sake, let us remember it is more common in primary. It occurs in 1/3 of the cases, and it is relatively rare in secondary form. Okay, the reason behind the rarity in secondary form I have already told you. That is my take on this. Books don't usually describe about it. Now, what is the most common extraglandular manifestation? An MCQ point, right? Most common extraglandular manifestation is basically arthralgia or a non-erosive arthritis. Arthralgia or non-erosive arthritis is the most common extraglandular manifestation. Apart from that, what other extraglandular manifestations we can see? These extraglandular manifestations can be divided into 4 major categories. One is non-specific. Then the second one is periepithelial, where there is epithelial infiltration of major organs, epithelial lymphocytic infiltration of important organs. Okay, so what are those important organs? Lung, liver, and kidneys. Okay. Then there may be some immune complex mediated manifestations, and also I have already discussed there is a risk of lymphomas that includes maltoma as well as non-Hodgkin's lymphoma, right? So what are the non-specific manifestations? They can experience myalgia, but remember myalgia is far less common, almost 50% less common than arthralgia and arthritis. That is why remember arthralgia or arthritis is the most common extraglandular manifestation of Sjogren syndrome. Patients can also experience Raynaud's phenomenon. So myalgia, arthralgia, arthritis, and Raynaud's phenomenon. The most common is arthralgia or arthritis. Now coming to periepithelial complications, yes, there is lymphocytic infiltration of the epithelium of important internal organs. So in lungs, the most common manifestation or most characteristic manifestation is basically interstitial pneumonitis. This is going to be known as lymphocytic interstitial pneumonitis. Lymphocytic interstitial pneumonitis. That is characteristic abnormality seen in Sjogren syndrome. Apart from that, yes, these patients are also at increased risk of developing interstitial lung disease, just like any other connective tissue disorder. Right? I don't connect them to be strongly associated like in systemic sclerosis. In case of systemic sclerosis and rheumatoid arthritis, there is a very strong association between interstitial lung disease and those disorders. Here there is association, but not that particularly strong. Right? Then in case of liver, it can cause primary biliary cirrhosis. In case of liver, it can cause primary biliary cirrhosis, and in kidneys, it can cause interstitial nephritis. Interstitial nephritis, mainly because of the lymphocytic damage. And the manifestation of this interstitial nephritis would be in the form of type 1 renal tubular acidosis, what we call as distal renal tubular acidosis, right? More of it we have already discussed on the renal tubular acidosis videos, and definitely revise those points, right? Type 1 renal tubular acidosis. Okay. Lymphomas, I have already told you, they are associated with the risk of maltoma as well as non-Hodgkin's lymphoma. Right? And sometimes there is formation of immune complexes, and those deposition can also cause manifestations. So it can cause small vessel vasculitis, which can manifest in the form of purpura, right? Which can manifest in the form of purpura. This immune complex mediated injury to the peripheral nerves is also a known complication, which can present as sensory or sensory motor polyneuropathy, right? Sensory or sensory motor polyneuropathy. Okay, so that is also one of the manifestation, and I particularly want you to remember this because this should be taken as a clue, as one of the potential clues towards the diagnosis. Yes, there are other autoimmune disorders where, especially immune complex mediated disorders, where there is polyneuropathy or mononeuritis multiplex occurring, right? So there also it becomes an important point as a differential diagnosis. Here also it's an important point. Remember this can be put it as a clue for the diagnosis. Okay, and it can also cause glomerulonephritis, not only interstitial nephritis. Interstitial nephritis is because of the lymphocytic infiltration, but immune complex deposition can also cause glomerulonephritis, mainly in the form of membranoproliferative GN. Membranoproliferative GN. Okay, so these are the extragranular manifestations. Okay, now before I move on, we'll just refresh this point, right? Most common Sjogren's syndrome and lymphoma risk. Right, most common is low-grade marginal B-cell lymphoma. That is the most common, and they can also get maltomas. Okay. Now coming to differential diagnosis. Now for individual symptoms, there are important differential diagnoses. For example, if you talk about xerostomia, right, atropine and related drugs, certain psychotropic drugs, they become important differential diagnosis. Similarly, for dry eyes, there may be other important differential diagnoses. I don't want to get into that because these are individual symptoms and they're associated differential diagnoses. When we see Sjogren syndrome as a whole, collectively, certain important differentials are mainly to differentiate it from sarcoidosis, because the parotid gland enlargement as well as dry mouth, dry eyes, all are seen in sarcoidosis, right? So what helps us to differentiate Sjogren's from sarcoidosis? Mainly the lack of autoantibodies. But remember, autoantibodies, mainly those anti-La and anti-Rho, are seen in 70 to 90% of the patients, and not all patients of Sjogren, right? So you cannot bank on only the autoantibodies, but lack, yes, more in favor of sarcoidosis. Then if you do a salivary gland biopsy, right, or any saliva, mainly we pick up the minor salivary gland, right? Even if you take a major like parotid salivary gland biopsy, what is it going to show? Here we see granuloma. Sarcoidosis is a granulomatous disease, right? But in case of Sjogren's, we see CD4 cells. We see CD4 cells. Okay, that is one important point. And obviously, you may be able to see increased ACE activity and various other abnormalities there, like calcium-related abnormalities and all in sarcoidosis patients. Then coming to another important differential diagnosis, HIV infection can cause Zika syndrome, not Sjogren's, but the dryness of mouth and dryness of the eyes. So there also we are not seeing the autoantibodies. The second feature that helps us to distinguish is if you do the biopsy of the salivary glands, it will be mainly caused by CD8 cells, not the CD4 cells, CD8 cells. And obviously the patient would be having a history of either the serological test would be positive or he would be already diagnosed as an HIV case, right? So that would be evident for us. The other thing we may notice is that in Sjogren's, yes, it is typically affecting the middle-aged women, but in case of HIV, generally males are more affected than females, and thus your patient is most likely to be a male, right? Now that is about differential diagnosis. Now coming to the final diagnosis, how do we diagnose? The diagnosis of Sjogren syndrome currently is based on the 2016 ACR-EULAR classification criteria. Yes, it is classification criteria, not the diagnostic criteria, but most of us clinicians follow this itself. Okay, so in this classification criteria, what we should remember is patients should meet all the inclusion criteria and he should not be satisfying any of the exclusion criteria, and then after that there is a scoring system and he should score more than 4 out of the possible score. If he is scoring 4 or more than 4, is meeting all the inclusion criteria and there are no exclusion criteria met, then the diagnosis or the case can be classified as Sjogren syndrome. So what are the inclusion criteria? Right. So inclusion criteria basically include these questionnaires, right? So patient should have at least one of the symptoms of oral or ocular dryness. So patient should have either dry mouth or dry eyes, and that is assessed by asking these 5 questions. Have you had daily persistent troublesome dry eyes for more than 3 months? He says yes. Done. Inclusion criteria satisfied. Or do you have a recurrent sensation of sand or gravel in the eyes? That is what I was describing as gritty sensation, right? Or do you use tear substitutes for more than 3 times a day? Another way of asking, do you have dry eyes, right? Have you had a daily feeling of dry mouth for more than 3 months? Or the last one, do you frequently drink liquids to aid swallowing of dry food? So these questionnaires are basically trying to extract whether the patient has dryness of mouth or dryness of eyes. Right? That is an important inclusion criteria. In the absence of any of these, right? Patient is not having any symptoms of dry eyes, patient is not having any symptoms of dry mouth, then we are not considering the diagnosis of Sjogren syndrome. That is the essence of this. Now we should have some exclusion criteria also. What are those? Basically, if the patient had in the past or currently being diagnosed with any of those conditions which can have a Sjogren syndrome like presentation, then it should be taken as an exclusion criteria. For example, if the patient had received head and neck radiation, that explains why they are having the gland dysfunction, right? So that is exclusion criteria. If patient is having acute active hepatitis C infection, active hepatitis C infection. When we were discussing the causes, I did tell you that it may be seen in hepatitis C, right? So in case of hepatitis C, we are not branding it as Sjogren syndrome, but we will call it as hepatitis C associated Zika syndrome. So it is a exclusion criteria. If patient is having AIDS or HIV, it is an exclusion criteria, and how to differentiate we have already discussed, right? We have discussed that point here, right? Predominantly young affected, biopsy showing more of a CD8 cell infiltration, and autoantibodies are usually negative, right? Then if the patient is associated with sarcoidosis, one more differential we have discussed how to differentiate from it. Right? Amyloidosis can also cause gland enlargement and dysfunction, so that also rules out, or it is an exclusion criteria. Right? Then the graft versus host disease is an exclusion criteria, and the last one is particularly important, IgG4 related diseases. Right? I was telling you about Mikulic's disease. So where there is infiltration of the glands by IgG4 positive lymphocytes. This is a separate set of disorders where like another organ which is commonly affected by the IgG4 related disorders apart from the salivary glands is pituitary, where it causes hypophysitis, right? It causes autoimmune hypophysitis. Pancreas can also affected in IgG4 related disorder, where it causes autoimmune pancreatitis, right? So that is about IgG4 related diseases. So if any of them are already diagnosed as having IgG4 related disease, it is excluded. The Sjogren syndrome is not considered in that case. Okay. So once we have made sure that patient is not satisfying any of the exclusion criteria and he satisfies the inclusion criteria of having dry mouth or dry eyes, then we go to this scoring system, and he has to score more than or equal to 4 out of this. So what are the scoring system? Okay. So I only want you to remember 2-3 important points from the scoring system, that having anti-rho positive gives some score. Okay. You may ask me, sir, why don't we have anti-La in this? Those two we are telling that they are characteristically associated with Sjogren's, right? The reason for that is anti-La never occurs in the absence of anti-rho. Anti-rho can occur. You may have anti-rho antibodies positive and anti-La negative, but anti-La positive and anti-rho negative doesn't occur. So anti-La is always seen in presence of anti-rho, and that is why that is only rho is included. Rho hai to La hoga. Okay. So that is one point to note. Okay. Then apart from that, we are also looking at some ocular staining score, which is known as Van Bridgeward score, right? Ocular staining score or Van Bridgeward score, which is one of the component. The details I think ophthalmology people would be covering. I only want you to remember the name, right? They can ask you an MCQ, which of the following is not a component of the ACR EULAR diagnostic criteria classification criteria for Sjogren syndrome, right? So there is ocular staining score or Van Bridgewald score. I am not sure if I am pronouncing it right because it's kind of spelled weirdly, but yeah, remember that. Okay. And then it also includes Schirmer's test, and the number is something I have already told you to remember, 5, right? Read at 5 minutes, less than 5 millimeter is supportive of diagnosis of keratoconjunctivitis sicca, and it gets a score of 1. And there is also a role of unstimulated whole saliva flow rate. Yeah, these are the components. And when patient scores more than or equal to 4, when it scores more than or equal to 4, then we classify the case as having Sjogren syndrome. Right? Now coming to treatment, unfortunately we don't have anything great to offer as a treatment because we haven't understood the pathophysiology so well so far, and most of the early clinical trials have not shown any great results with the conventional treatment approaches. So what do we do right now? We mainly offer them symptomatic or supportive care. Dry eyes, moisten the eyes with the tear supplements and all, that is the routine approach. And if those patients who are really bothered by, if it is xerostomia, then you can ask them to achieve some lozenges which will help secrete some amount of saliva before feed. And if it is dry eyes, give them the eye drops which contain lubricants. That is the routine approach, symptomatic approach. If they have developed complications, we treat them according to how we would be treating those complications. Now arthritis is one common manifestation. That is the most common extraglandular manifestation, right, occurring in up to 30% of the patients. And though there are no important trials or major trials which show that this particular approach is beneficial, most of us continue to treat them with hydroxychloroquine, methotrexate or steroids, right? The commonly followed drug is hydroxychloroquine. Okay, so that's all about the management of Sjogren syndrome. So most important points I want you to remember are basically about differentiation from AIDS and sarcoidosis. That's one important table that you should remember. MCQs are possible from that table. Then the second thing I want you to remember about is the latest diagnostic criteria and the scoring pattern and the components of that scoring system, right? Those two tests that we spoke about, right? The ocular staining score and Van Bijesteveld score. I don't know how exactly it is pronounced. Yeah, that is the score. And Schirmer's test. Schirmer's test, the number is particularly important, right? And certain biopsy findings, and you may anticipate image-based questions from this. So be aware about that, because they may give you a history. They may tell that patient presented with salivary gland swelling. She complains of dry eyes and she complains of dry mouth, and they may give you this image and you should be able to pick up. They will tell you that this is a minor salivary gland biopsy, and then what is the diagnosis, or which of the following statement is false regarding the diagnosis. And they may mention that these cells are going to be IgG4 positive, or they may mention that these cells are going to be CD8 positive. So these are CD4 positive, right? Okay, that's all about Sjogren syndrome. I will be posting similar videos on this YouTube channel as we go along, right? So connect to me on my Telegram group, which is known as Dr. Patil's Medmania, the link to which I will be sharing on the description of this video. Thank you guys.